Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 231 of our pharmacotherapy series, which majors in infectious diseases. This question refers to patient R.O.G. in part 230 of our series. In light of the positive culture for serratia, his increased respiratory secretions, and a worsening chest radiograph, ventilator-associated pneumonia is likely present. Pending susceptibility results, R.O.G. is empirically started on imipenem, cilastatin and gentamicin. In review of his patient records, R.O.G. has no known allergies. Are there equally effective, less toxic options for this patient? First, I will discuss adverse effects and toxicities. Before antimicrobial therapy is started, it is important to elicit an accurate drug and allergy history. When allergy has been reported by the patient, it is necessary to determine whether the reaction was intolerance, toxicity, or true allergy. For example, gastric intolerance caused by oral doxycycline is common. However, this adverse effect does not represent an allergic manifestation. Although R.O.G. has no known allergies, neither imipenem, cilastatin nor gentamicin are optimal choices. Imipenem, cilastatin is associated with seizures, particularly in patients with renal failure and in doses in excess of 50 mg per kilogram per day. Considering R.O.G.'s acute onset of renal failure and his history of seizures, other carbapenems, such as meropenem or doripenem, or alternative classes of antibacterials would be preferable. Gentamicin similarly may not be a good choice in R.O.G. His increased age and declining renal function predispose him to aminoglycoside nephrotoxicity and ototoxicity, which can be cochlear and vestibular. A reasonable recommendation pending susceptibility results would be to discontinue imipenem and gentamicin and treat with meropenem or doripenem with or without a fluoroquinolone.
Let's now consider concomitant disease states. Concomitant disease states should also be considered in the selection of therapy. As discussed above, older patients with hearing deficits are poor candidates for potentially ototoxic aminoglycoside therapy. Diabetic or kidney transplant patients with candidemia may be better treated with fluconazole or an echinocandin rather than nephrotoxic amphotericin B products. Patients with a pre-existing seizure history should not receive imipenem, cilastatin if less toxic therapy can be used. In summary, the toxicologic profile of a drug must be taken into account in the selection of antimicrobial therapy.
The next question reads, what factors should be included in calculating the cost of R.O.G.'s antimicrobial therapy? The true cost of antimicrobial therapy is difficult to quantify. Although acquisition cost traditionally has been the primary factor in the overall cost of therapy, drug administration labor costs, i.e., nursing and pharmacy, and the use of IV sets, piggyback bags, and infusion control devices must be included in the analysis. As a result, a drug that must be administered several times daily, such as intravenous penicillin, will incur increased administration costs compared with one, such as ceftriaxone, that requires once-a-day dosing. Some drugs, such as aminoglycosides, are associated with increased laboratory costs, e.g., aminoglycoside serum concentrations, serum creatinine, and audiometry, that are not required for other agents, such as the third-generation cephalosporins and quinolones. Similarly, drugs with a high potential for misuse or toxicity can be associated with increased costs because of monitoring, e.g., medication use evaluation, pharmacokinetic monitoring. If meropenem with or without ciprofloxacin had been selected for R.O.G, this therapy would be expected to be associated with relatively few laboratory costs. However, the broad spectrum of activity of these agents, potential for misuse, and development of resistance might, however, result in increased monitoring costs and overall cost to society. Costs that are difficult to quantitate include those associated with failure of antimicrobial therapy and antimicrobial toxicity. Ineffective or toxic therapy can prolong hospitalization and may require expensive interventions, such as hemodialysis, mechanical ventilation, and intensive care unit admission. The net effect of these latter costs can be significantly greater than the acquisition and administration costs of antimicrobial therapy. In summary, determining the true cost of antimicrobial therapy is complex. Acquisition cost, IV bags, infusion controllers, and labor must be incorporated into the analysis. Although they are difficult to estimate, other costs, including antibiotic toxicity and failure of therapy, should also be included. The next question reads, the serratia was determined to be susceptible to ciprofloxacin. Oral ciprofloxacin was considered for the treatment of R.O.G's presumed serratia pneumonia, but the IV route was prescribed. Why is the oral administration of ciprofloxacin reasonable, or unreasonable, in R.O.G's clinical scenario? The proper route of antibiotic administration depends on many factors, including the severity of infection, antimicrobial oral bioavailability, and other patient factors. In patients who appear septic, blood flow often is shunted away from the mesentery and extremities, resulting in unreliable bioavailability from the gastrointestinal tract or muscles. Consequently, hemodynamically unstable patients should always receive antimicrobials by the IV route to ensure therapeutic antimicrobial levels. Furthermore, some drug interactions with oral agents can result in subtherapeutic serum concentrations, e.g., reduced bioavailability associated with concomitant quinolone and antacid administration and the decreased absorption of itraconazole with concurrent proton pump inhibitor therapy. R.O.G is clinically septic with a possible serratia pneumonia. Considering his unstable state, the bioavailability of oral ciprofloxacin cannot be guaranteed, thus, he should be treated with IV antimicrobials. The next question reads, what dose of IV ciprofloxacin should be given to R.O.G? What factors must be taken into account in determining a proper antimicrobial dose? The choice of dosing regimen is based on many factors. Selection of the appropriate dosage should be based on evidence confirming the efficacy of the dosage in the treatment of a specific infection. Patient-specific factors, including weight, site of infection, and route of elimination, must also be considered in dosage selection. The patient's weight is important, particularly for agents with a low therapeutic index, e.g., aminoglycosides, imipenem-cilastatin, and flucytosine. These drugs should be dosed on a milligram per kilogram per day basis. Other agents with a more favorable adverse effect profile, such as cephalosporins, are less likely to require weight-specific dosing in most disease states. I will briefly talk about site of infection. Site of infection results in different dosage requirements. An uncomplicated urinary tract infection requires lower doses considering the high urinary drug concentrations that are achieved with most renally cleared agents. In contrast, a more serious upper urinary tract infection, such as pyelonephritis, requires increased doses to ensure therapeutic drug levels in tissue and in serum. Next I will discuss anatomic and physiologic barriers. Anatomic and physiologic barriers must also be considered in evaluating a dosing regimen. For example, penetration into cerebrospinal fluid requires high doses to ensure adequate antimicrobial concentrations. Vitreous humor and the prostate gland are additional sites in which therapeutic antimicrobial concentrations are more difficult to achieve. Next I will talk about route of elimination. Route of elimination must also be considered in the dosage calculation. In general, antimicrobials are eliminated renally or non-renally, metabolic or biliary. Renal function can be estimated via 24-hour urine collection or with equations, such as the Cockcroft and Gault equation. Several anti-infectives are eliminated renally. Most beta-lactams are eliminated by the kidney. In contrast, ceftriaxone and most antistaphylococcal penicillins, e.g., nafcillin, oxacillin, and dicloxacillin, are eliminated both renally and non-renally. Aminoglycosides, vancomycin, acyclovir, and ganciclovir are cleared primarily by the kidney. Thus, dosage adjustment is recommended for these drugs in patients with renal failure. Because azithromycin, clindamycin, and metronidazole are primarily eliminated by the liver, no dose reduction is required in renal failure for these agents. Using the Cockcroft and Gault equation, R.O.G's age, that is 63 years, weight, which is 70 kg, and current serum creatinine, 3.8 mg per deciliter, results in a calculated creatinine clearance of 14 ml per minute. R.O.G normally would be given an IV dosage of ciprofloxacin at 400 mg every 12 hours. His increasing creatinine, however, suggests that his dosage should be decreased to 200 to 300 mg every 12 hours. Although renal function can be approximated with the use of the Cockcroft and Gault equation, or a similar equation, hepatic function is more difficult to evaluate. No standard liver function test AST, ALT, or alkaline phosphatase has been demonstrated to correlate well with hepatic drug clearance. Some tests, such as PT-INR, and albumin, are markers of hepatic function, but even these tests do not clearly predict drug clearance. Patients receiving hemodialysis or continuous hemofiltration provide additional dosing challenges. Regarding patient age, it is important to note that most dosing information is derived from a younger, relatively healthy patient population. It is clear that the very young and the elderly have a decreased ability to clear drugs, thus, dosage requirements for many agents are likely to be decreased in neonatal and geriatric patients. Next I will talk about fever and inoculum effect. The impact of other factors on the selection of an antimicrobial dose is less clear. Fever increases and decreases blood flow to mesenteric, hepatic, and renal organ systems, and it can either increase or decrease drug clearance. Inoculum effect has taken place when higher concentrations of a bacterial inoculum result in an increase in the MIC. As an example, piperacillin may demonstrate an MIC of 8.0 micrograms per milliliter against Pseudomonas aeruginosa at a concentration of 105 colony-forming units per milliliter. However, at 109 colony-forming units per milliliter, the MIC may increase to 32 to 64 micrograms per milliliter. This phenomenon is well recognized, particularly with beta-lactamase-producing bacteria treated with beta-lactam antimicrobials. The more stable the antimicrobial is to beta-lactamase, the less the influence of the inoculum effect. Aminoglycosides, quinolones, and imipenem-cilastatin appear to be less affected by the inoculum effect than beta-lactams. The inoculum effect probably is most relevant in the treatment of a bacterial abscess, in which extremely high concentrations of bacteria would be expected. As a result, antimicrobials that are more susceptible to the inoculum effect may require increased drug dosages for optimal outcome in the treatment of abscesses. My next question to you reads, R.O.G's respiratory status remains unchanged, thus, the ciprofloxacin is discontinued and cefepime and gentamicin are started empirically. The use of a prolonged 3-hour IV infusion of cefepime is being considered in R.O.G. In addition, the use of single daily dosing of gentamicin is being discussed. What is the rationale for these approaches, and would either be advantageous for R.O.G.? Beta-lactams, such as cefepime, are not associated with increased bacterial killing with increasing drug concentrations. Pharmacodynamic activity with beta-lactams best correlates with the duration of time that antimicrobial levels are maintained above the MIC. The animal model suggests that beta-lactam antimicrobials should be dosed such that their serum levels exceed the MIC of the pathogen as long as possible. This observation appears to be most important in the neutropenic model, in which the use of a constant infusion more reliably inhibits bacterial growth compared with traditional intermittent dosing. An additional benefit of the use of constant infusions of beta-lactams is that smaller daily doses appear to be as effective as higher doses administered intermittently. Other than this latter outcome, it is unclear, however, whether constant infusions have any distinct advantages or disadvantages compared with usual dosing of beta-lactams. The efficacy of quinolones, vancomycin, and daptomycin best correlates with the peak plasma concentration to MIC ratio or area under the curve AUC to MIC ratio. In light of this pharmacodynamic principle, it is possible that ciprofloxacin was underdosed in this patient, contributing to the therapeutic failure, particularly if the MIC was in the upper range of susceptibility for this agent. Aminoglycosides traditionally have been administered every 8 to 12 hours to achieve peak serum gentamicin levels of 5 to 8 micrograms per milliliter to ensure efficacy in the treatment of serious gram-negative infection. Gentamicin troughs of greater than 2 micrograms per milliliter have been associated with an increased risk for nephrotoxicity. These studies attempting to correlate efficacy and toxicity with serum levels and the association of peaks or troughs with clinical outcomes have been questioned. Vancomycin troughs of 5 to 10 micrograms per milliliter have been traditionally recommended, however, current recommendations suggest higher troughs, that is 10 to 20 micrograms per milliliter, depending on the pathogen, site of infection, and severity of illness. Several antimicrobials, e.g., aminoglycosides, have been associated with a pharmacodynamic phenomenon known as a post-antibiotic effect, PAE. PAE is delayed regrowth of bacteria after exposure to an antibiotic, i.e., continued suppression of normal growth in the absence of antibiotic levels above the MIC of the organism. As an example, if Pseudomonas aeruginosa is cultured in broth, it will multiply to a concentration of 109 CFU per milliliter. If piperacillin is added in a concentration above the MIC for the organism, a reduction in the bacterial concentration is observed. As described previously, a beta-lactam antibiotic should be present in concentrations above the MIC to optimize its time-dependent killing. When piperacillin is removed from the broth, immediate bacterial growth takes place. If the above experiment is repeated with gentamicin, a reduction in bacterial CFU is observed. In contrast to that observed with beta-lactam antibiotics, if the gentamicin is removed from the system, a lag period of 2 to 6 hours takes place before characteristic bacterial growth occurs. This lag period is defined as the PAE. APAE has also been observed with quinolones and imipenem C-listatin against gram-negative bacteria. Although most beta-lactam antibiotics, such as anti-pseudomonal penicillins or cephalosporins, do not exhibit PAE with gram-negative organisms, PAE has been demonstrated with beta-lactam with gram-positive pathogens such as Staphylococcus aureus. I will briefly talk about once-daily dosing of aminoglycosides. As a result of PAE and other pharmacodynamic factors, certain antimicrobials may be dosed less frequently. The greatest clinical experience has been with the aminoglycosides in the treatment of gram-negative infection. Earlier data suggested that the maximal aminoglycoside peak level to MIC ratio correlates well with clinical response. Thus, the higher the achievable peak, the greater likelihood of a favorable outcome. Consequently, greater, less frequent doses of aminoglycosides should work at least as well as the more traditional lower, more frequent doses. Once-daily dosing of aminoglycosides in the treatment of gram-negative infection is as efficacious as traditional multiple daily dosing. Single daily dosing of aminoglycosides has been investigated primarily in patients with normal renal function, and few critically ill patients have been treated with this non-traditional regimen. Thus, patients in septic shock are less clear candidates for once-daily dosing. The utility and proper timing of serum aminoglycoside concentrations and association with clinical outcomes are debatable with non-traditional once-daily aminoglycosides. In summary, the use of a prolonged IV infusion of cefepime is possible in R.O.G, but the benefit of this mode of administration is not clear. Considering the severity of R.O.G's infection and his elevated serum creatinine level, he is not a candidate for single daily dosing of aminoglycosides, i.e., 5 to 6 mg per kilogram every 24 hours. Independent of the aminoglycoside-associated PAE, his current renal function requires a reduced gentamicin dose to treat his infection. My next question to you reads, ceftriaxone, marketed as Rosefen, rather than cefepime, is being considered for the treatment of R.O.G's infection. Ceftriaxone is more highly protein-bound than cefepime. Why is protein binding important in the selection of therapy? I will begin by commenting that free, i.e., unbound, rather than total drug levels are best correlated with antimicrobial activity, and the degree of protein binding may have important clinical consequences in some patients. Chambers and colleagues reported treatment failures with the highly protein-bound cefonicid, which is 98% protein-bound, in patients with endocarditis caused by Staphylococcus aureus. Despite achievable serum drug concentrations well above the MIC of the organism, breakthrough bacteremia occurred in 3 of 4 patients. Although total drug concentrations greatly exceeded the MIC of the pathogen, free concentrations were consistently below the level necessary to inhibit bacterial growth. Similar experiences have been reported with daptomycin, 90% to 93% protein-bound. Thus, clinical cure appears to be more likely if unbound antibiotic concentrations exceed the MIC of the infecting organism. Although ceftriaxone is 85% to 90% protein-bound, the free concentrations probably remain far above the MIC of the serratia. Therefore, protein binding considerations are unlikely to be important in the treatment of R.O.G's infection. My next question to you reads, despite appropriate treatment, R.O.G is unresponsive to antimicrobial therapy. What antibiotic-specific factors may contribute to antimicrobial failure? Antimicrobials may fail for various reasons, including patient-specific host factors, drug or dosage selection, and concomitant disease states. One of the most common reasons for antimicrobial failure is drug resistance. Several clinically important pathogens have been associated with emergence of resistance during the past decade, including Mycobacterium tuberculosis, Enterococci, gram-negative rods, Staphylococcus aureus, Streptococcus pneumoniae, and others. Of particular concern is the isolation of glycopeptide-resistant Staphylococcus aureus, and multidrug-resistant Acinetobacter and Pseudomonas. Development of resistance during therapy, although less common than initial intrinsic resistance, may also account for failure to respond to therapy. Organisms that produce extended-spectrum beta-lactamase or AMP-C beta-lactamases may be unresponsive to beta-lactam therapy despite associated in vitro susceptibility. Superinfection may also play a role in the unsuccessful treatment of infection. Superinfection has taken place when a new pathogen resistant to the current antimicrobial regimen is isolated. If R.O.G's ceftriaxone-treated serration pneumonia subsequently worsens and a tracheal aspirate returns positive for Pseudomonas aeruginosa, then supercolonization and, perhaps, superinfection have occurred. I will briefly comment about combination therapy. Most infections can be treated with monotherapy, e.g., an Escherichia coli wound infection is treatable with a cephalosporin. Some infections, however, require two-drug therapy, including most cases of enterococcal endocarditis and perhaps certain Pseudomonas aeruginosa infections. Hilf and colleagues studied 200 consecutive patients with Pseudomonas aeruginosa bacteremia and demonstrated a 47% mortality in those receiving monotherapy, anti-pseudomonal beta-lactam or aminoglycoside, versus 27% in those in whom two-drug therapy was used. Thus, monotherapy appeared to contribute to antimicrobial failure in this specific study. In contrast to the findings of the previous trial, almost all later investigations do not support the use of two drugs over monotherapy in the treatment of serious gram-negative infection, including Pseudomonas aeruginosa. An exception to this rule is bacteremia caused by Pseudomonas aeruginosa in neutropenic patients. If two antimicrobials are used in the treatment of infection, one of three sequelae will result: indifference, synergism, or antagonism. Indifference occurs when the antimicrobial effect of drug A plus that of drug B equals the anticipated sum activity of the two drugs. Although numerous definitions exist, synergism generally occurs when the addition of drug A to drug B results in a total antibiotic activity greater than the expected sum of the two agents. Antagonism occurs if the addition of drug A to drug B results in a combined activity less than the sum of drug A plus drug B. An example of antagonism is the combination of imipenem with a less beta-lactamase, stable beta-lactam, such as piperacillin. If Pseudomonas aeruginosa is exposed to imipenem C-listatin and piperacillin, the imipenem C-listatin induces the organism to produce increased beta-lactamase. Imipenem C-listatin is remarkably beta-lactamase stable and is not degraded by this beta-lactamase. In direct contrast, piperacillin is easily degraded by the beta-lactamase. Thus, imipenem C-listatin antagonized the effectiveness of piperacillin. Antagonism is not unique to antibacterials. Itraconazole may antagonize amphotericin B in the treatment of certain fungal infections. The next question reads, what pharmacologic or pharmaceutic factors may be implicated in failure of therapy? Subtherapeutic dosing regimens are commonplace, particularly for agents with a low therapeutic index, such as the aminoglycosides. For example, a serious gram-negative pneumonia may not respond to aminoglycoside therapy if the achievable peak gentamicin serum levels are only 3 to 4 micrograms per milliliter. Considering that only 20% to 30% of the aminoglycoside penetrates from serum into bronchial secretions, only 0.5 to 1.0 micrograms per milliliter may exist at the site of infection, a level that may be inadequate to treat pneumonia. Another example of dosing contributing to antimicrobial failure centers on the use of loading doses. Aminoglycosides or vancomycin should be initiated with a loading dose, particularly in patients with renal failure. If the clinician neglects to use a loading dose, it may take several days before a therapeutic level is achieved. As described previously, yet another reason for subtherapeutic antimicrobial levels and potential drug failure is reduced oral absorption secondary to drug interactions, e.g., concomitant oral ciprofloxacin with antacids or iron. An emerging problem relates to the use of vancomycin in the treatment of serious methicillin-resistant Staphylococcus aureus (MRSA) infection. By CLSI standards, an isolate of MRSA with an MIC of 2 micrograms per milliliter is considered susceptible. Current vancomycin dosing schemes are designed to achieve an AU/C to MIC ratio of equal to or above 400 to ensure maximal efficacy. However, a meta-analysis of patients with Staphylococcus aureus bacteremia demonstrated no differences in the risk of death when comparing patients with Staphylococcus aureus exhibiting high vancomycin MIC equal to or above 1.5 mg per liter to those with low vancomycin MIC below 1.5 mg per liter. The infection site also potentially contributes to antimicrobial failure. Most antimicrobials concentrate in the urine, resulting in therapeutic levels even with low doses. In some infections, such as meningitis, prostatitis, and endophthalmitis, antimicrobial penetration to the site of infection may be inadequate. Agents that penetrate well into these sites are associated with a more favorable outcome. Another potential reason for antimicrobial failure is inadequate therapy duration. A woman with a first-time uncomplicated cystitis may respond adequately to a 3-day course of an antibiotic. In contrast, patients with recurrent urinary tract infections are not candidates for this short course of therapy, however, and failure would be expected with only 3 days of therapy. The next question reads, what host factors may contribute to the failure of antimicrobial therapy? Several host factors may limit the ability of an antibiotic to cure infection. Infection of prosthetic material, e.g., IV catheters, orthopedic prostheses, mechanical cardiac valves, and vascular grafts, is difficult to eradicate without removal of the hardware. In most cases, surgical intervention is necessary. To treat R.O.G's IV catheter infection adequately, removal of his central intravenous catheter would be optimal. Similar to removal of prostheses, large undrained abscesses are difficult, if not impossible, to treat with antimicrobial therapy. These infections generally require surgical drainage for successful outcome. Diabetic foot ulcer cellulitis may not respond adequately to antimicrobial therapy. Reasons for antimicrobial failure in patients with diabetes include poor wound healing and reduced delivery of antibiotics to the infection site. Immune status, particularly neutropenia or lymphocytopenia, also affects the outcome in the treatment of infection. Profoundly, neutropenic patients with disseminated Aspergillus infections are unlikely to respond to even the most appropriate antifungal therapy. Similarly, patients with AIDS, who have low CD4 lymphocyte counts, cannot eradicate various infections, including those caused by cytomegalovirus, atypical mycobacteria, and cryptococci. Once these factors have been eliminated as causes for antimicrobial failure, non-infectious sources must be ruled out. As discussed, malignancy, autoimmune disease, drug fever, and other diseases must be evaluated. The last question reads, other than initiation of adequate antimicrobial therapy, what adjunct measures can be considered in this patient with septic shock? We will discuss the 2013 Surviving Sepsis campaign. International guidelines for management of severe sepsis and septic shock consultants developed key recommendations toward the early goal-directed resuscitation of the septic patient. These recommendations include the use of sepsis bundles, i.e., multiple interventions taking place at the same time. Key recommended adjuncts include administration of broad-spectrum antibiotics within 1 hour of diagnosis of septic shock, administration of either crystalloid or colloid fluid resuscitation, and norepinephrine or dopamine to maintain mean arterial pressure of at least 65 mm of mercury. In addition, stress-dose steroid therapy can be given to those patients whose blood pressure is poorly responsive to fluid resuscitation and vasopressors. While one might expect improved survival with adherence to such guidelines, the results have been mixed. A large meta-analysis evaluated the influence of performance improvement programs regarding compliance with sepsis bundles. These programs have been found to be associated with increased adherence to resuscitation and management sepsis bundles and with reduced mortality in patients with sepsis, severe sepsis, or septic shock. In contrast, in patients with septic shock who were identified early and received intravenous antibiotics and adequate fluid resuscitation, hemodynamic management according to a strict early goal-directed therapy protocol did not lead to an improvement in outcome. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arora, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 232.